everyone for attending my talk. My name is Shi-Long Lu. I'm a professor at the University of Colorado School of Medicine. I'm also a founder and the president of Summit Biolabs, which is a university startup focusing on saliva diagnostics for cancer and infectious disease. For the next 30-minute talk, I hope that I can convince you the advantages of using saliva in clinical testing for cancer and infectious disease, specifically for those diseases derived from the quote-unquote upper aerodigestive tract, the UADT. And this diagram actually is described of the anatomical location of UADT. I'm showing here that, it includes all the parts above your neck. They have the nose, oral cavity, throat, larynx, and down to esophagus, bronchi, and lung. And for the nose, throat, oral cavity, and larynx, in clinically, cancer derived from those regions cause a head and neck cancer. The other part of the upper aerodigestive tract is infectious disease, and the most common disease is the respiratory infections, such as the COVID-19 and flu. So then I think in my talk, basically I have two parts. The first part, I will talk about HNKlear, which is a saliva-based test for head and neck cancer. I'm going to talk those from our lab invention to clinical validation and application. And the second part, I'm going to talk about what we have contributed in fighting the pandemic, talk about the COVID-FAST, which is the RNA extraction-free method using either saliva or swab. And also, I'm going to share our real-world experience for using those tests in COVID-Tech, Colorado, which is the main drive for the COVID testing efforts in the state of Colorado. So first, let's talk about the head and neck cancer. Nearly over 90% of the head and neck cancer are squamous cell carcinoma. And it's depending on the location, it's roughly classified as 3 major SCC, or i.e. squamous cell carcinoma. So it's the oral cavity, or called oral SCC, and oropharyngeal SCC, and laryngeal SCC. So it's the 7th most common cancer in US, but the prevalence or the survivors actually rank even higher than its incidence. It's a third most common with the cancer survivors in US. And the smoking and drinking occupied majority of the etiological factors of disease causing, particularly in the SCC from oral cavity and the larynx. Recently, the HPV infection contributes a significant portion of head and neck cancer, particularly in the oropharyngeal SCC. So similar to other cancers, 5-year survival is highly associated with the disease you identified. And unfortunately, most of the patients, when they diagnose, they're already in advanced stage. And over 30% of the patients will have a recur of the cancer come back within 2 years. So it's clearly the unmet medical need for early detection of head and neck cancer, while it still allow more treatment plan. So this slide showing the advantages of saliva over blood for head and neck cancer detection. You may heard a lot about liquid biopsy, but most of the liquid biopsy are blood-based. But actually showing in this diagram, you can see for a cancer being detectable in the blood vessel, cancer need to progress to a certain stage, which allow them to cross or invade the tissue boundaries and get into the blood vessel. Given the saliva anatomical proximity to head and neck cancer, you're able to detect head and neck cancer while it's in a very early stage, which is still in the local or called in situ stage. The current standard care for head and neck cancer include physical examination such as the palpation. Doctor may do some scopy detection, and imaging include PET scan, MRI, while in the suspicious area, they always do the biopsy. So the saliva test, comparing to those standard care, at least benefits from both the patient experience and the clinically. Given saliva collection's convenience, non-invasive nature, and less expensive than imaging, it will predict to significantly improve the patient compliance for their follow-up, which is one of the limiting factors for improving the survival. The other part is the clinical benefits. Since we have those multiple times testing, you can able to detect the cancers earlier than the standard care, which results a time shifting. This one has potentially increased the stage shifting, which we can do more curative treatment instead of just palliative treatment, which will ultimately lead to a survival improvement. In addition, based on the saliva test, you can do the individualized surveillance plan, and also based on the marker, you can do the precisional treatment. So next few slides is our data for the HNKlear, and this slide just summarize how we start. So the biomarkers we were using for head and neck cancer is a combination of a DNA methylation and the microRNA. So by browsing the genome for the genomic loci for microRNA, we identify the CPG island, which has a potential to be a biomarker. And then we go through the cell lines, tissues, and the saliva. In the end, the markers is composed with the 7 methylation genomic loci for microRNA, what we call mgmiR. And we also validate those marker performance in about 300 cases of tissues and 200 cases of saliva. So this is the summary of the ROC curve for individual markers, and together with the composition of the 7 markers together from both the tissue in A and saliva in B. So on the left side, you see the ROC curve. You see a composition of the 7 markers give the best ROC curve compared to the individual markers. On the right side of the table, this is the random forest analysis, which rank the marker performance and also include demographic information such as age and smoking status. These 2 tables summarize our performance for sensitivity and specificity in tissue on left side and saliva on right side. So this has been done with the logistic regression. You can see in the red box, in the combined one, the sensitivity and specificity in tissues are all about 90%, while in saliva, the sensitivity is nearly reached 85%, while the specificity is 95%. On the combined two is we include age as additional factors, and you can see that include age do not contribute significantly of the marker performance. We then use the assay. I'll just remind again, assay we called HNKlear performance to correlate with the clinical pathological factors. So the first is we want to see whether they have a differences between the different location, like oral cavity, oral pharyngeal, and then laryngeal, and the HNKlear basically detect equally on those three different type of the head and neck cancer. The assay tends to detect more HPV positive cases than negative cases, as shown in the lower of the left table. More importantly, the assay can detect tumors when tumors are still very small, like the T1 stage, or no metastasis at the N0, and also stage 1. So these slides give a more mechanistic view or biology of HNKlear testing and how we're going to define those tests in the clinical application. So similar to the target gene regulation, the DNA methylation is also strongly regulated microRNA. And I'll just remind everyone, microRNA is a novel class of the molecule, which is a very potent molecule to regulate its target gene's expression through binding to the 3-UTR. I'm showing here in a normal situation on the left side, while no major methylation happens in the CPG island, the microRNA 1 can express in the certain level which can regulate or inhibit the oncogene A, make it silencing in the normal cells. While when the hypermethylation happens in the CPG island, it will reduce or silence the microRNA 1, which will reduce the inhibition or regulation on oncogene A, will cause oncogene activation and cause the cancer cell development. So you can see that we have three ways to application of this microRNA can use as a diagnostic purpose, and also we can use this as a companion biomarker for biopharma. And last, you can even deliver the microRNA mimic to as a therapeutic approach. So this slide summarizes our data on functional characterization of the microRNA for the head and neck cancer. On the very left slide is showing the methylation level highly associated with the expression level. Methylation level showing on the up and the expression level showing on the bottom. The middle figure showing when we deliver the microRNA mimics, it can significantly inhibit the cell proliferation and also reduce sphere forming in C and the set population size in D. So both C and D are markers for cancer stem cell in head and neck cancer. And on the very right, we also found and validate a molecule called EZH2 as downstream target for the microRNA. So EZH2 is also a very potent regulator for cancer stem cells in head and neck. So this slide basically summarizes based on the NCCN guideline for what current a treatment plan for head and neck cancer, while the lower yellow part is our predict HNKlear has potential in the clinical utilities. So it depending on the stage, head and neck cancer either undergoing surgeries or radiation therapies, and the chemotherapies, the HNKlear can fit into all three different stages as pre-treatment for the clinical outcome prediction, or the post-treatment to see the treatment response, and also on the follow-up to see whether you can find the recurrence earlier and improving the clinical outcome. So this is data for our pre-treatment stratification use HNKlear in saliva and tissue. You can clearly see that HNKlear can separate the pre-treatment patient into high and low risk for their progression-free survival based on the markers. And this slide showed before and post-treatment, the marker levels at the post-treatment are highly associated with clinical outcomes such as the recurrence and death. Last, this is some pilot data for our longitudinal study for head and neck cancer. You can see that in 14 patients who had a recur or death, 13 test positive by HNKlear, in contrast with 29 patients has no recurrence, 23 are test negative. So there are still 6 patient test positives, and we are currently follow up those patients for their clinical outcome. And the right table basically a few examples to show the top 5 marker or HNKlear positive correlates with the recurrence, while the lower 5 test negative correlates with the recurrence negative. Most importantly, if you look at HNC16 patients, the lead time for the saliva test for the HNKlear saliva test as positive has 336 days lead time ahead with the imaging for detect the recurrence. So the current ongoing clinical trial has been doing for HNKlear in head and neck cancer. As I highlight here, we're aiming to evaluate whether HNKlear is compatible or non-inferiority to the medical imaging, and also using those, we can finalize the clinical trial to validate HNKlear can really detect cancer earlier than current clinical practice. So that's my first part of talk about the cancer piece, and now move to the infectious disease part. Here is specifically on COVID. So this slide summarizes what we have contributed to a SARS-CoV-2 detection. We have 4 IP from CU, Summit Biolabs, and WashU. I will briefly go through with you about the 4 different test application invented through this joint collaboration. COVID-Fast is extraction-free method. VOC-Fast is the proxy PCR for variant of concern for COVID. HNKlear is the assay developed for viral load monitoring, and Spit and Swab is the new assay combination with both saliva and swab. So first is the COVID-Fast, which is a extraction-free COVID-19 test, highly accurate, rapid, and low cost. So depending on the sample, either you use those straw for saliva collection, or you use this swab with a proximal breakpoint for swab. The reason we're using this, as you see the yellow tubes, is later we can all move this sample collection into a 2 ml cryo valve, which fits our high throughput detection workflow. And the Saliva-Fast is the most accurate direct PCR saliva test, while the Swab-Fast, by using our proprietary viral transport buffer, this is the first direct-to-PCR nasal swab test. And as I mentioned at the beginning, work with the COVID Check Colorado. By August 28th, we have done 87,000 tests already for people in Colorado, and we found the positive rate at about 5.6%. So next few slides, I'm showing you the analytical validation for our extraction-free methods in both saliva and swab. As you see in this table, figure A and B, basically there are no differences for the CT when you're comparing the assay with and without RNA extraction. This has been done in the analytical level using the contrived samples. This is also an analytical validation for a standard curve and also the limit of detection, LOD. So the LOD for both saliva fast and swab fast is a 4 copy per microliter. This slide is the clinical validation using the clinical sample. You see that A and B is the saliva versus swab, and with and without RNA extraction, basically there are no differences for the N1 detection. Demonstrate the extraction-free method is at least equivalent to the RNA extraction method. So the second is the VOC fast. Basically, it's a proxy PCR for variant of concern. And we all know that now is predominant about Delta variant, but back to May, the variant of concern of VOC listed on the CDC website alpha, beta, and gamma variants. And we have developed proxy PCR specifically detect for those VOC. So first, we want to see that all those 3 variants won't affect our performance as a wild type. So showing here for the 4 different positive controls, the 3 variants comparing to wild type, there are no performance diminished based on the variants for our COVID fast detection. We then design a primers and process specifically for those VOC detection, and this is the analytical validation. The top panel on A is the validation of the 4 different primer sets to detect they're both on the B117 positive control versus the wild type. So the primer and probe set for N is eliminated because these primers has a non-specific amplification when detect a wild type when the copy number is over 10,000. So we then use ORF and the S1 primers to do a variant separation. As you see that ORF primers basically can screen all the 3 variants together, B117, 351, and the P1, while the S1 primers can separate B117 from the other 2 variants. So this is our proxy PCR. We then send our samples to Biography, which is a NGS company in a black fashion for the validation of our proxy PCR. And you can see here that while in the 12 positive cases for both ORF and S1, NGS results confirm they are all B117 variants. And for the 2 samples, one is ORF positive while S1 negative. The NGS results showing one is P1, one is B1351. And for the remaining negatives for both ORF or S1, the NGS showing none of them are the 3 VOCs showing here. So the concordance for the VOC positive and the negative for VOC is 100%. So this is just the period of time we're using this proxy PCR by the end of May 2022. You see that the weekly VOC incidence using our proxy PCR is gradually increased, but after May, we stopped doing the variant detection with more of the Delta variant appearing, and right now being Delta variants being pretty dominant over rest of the variants. So the third is we also developed a assay we call it HNKlear for a viral load monitoring. And I'm going to show you some data for our longitudinal study. We have over 200 time points of sample collection from 19 COVID positive patients. This is the one example of patient 35. You see the red dot is using the swab sample, while the green is using saliva sample. And we have the patient collect a morning and the afternoon for both twice collection a day. This is over 24 days with all different time points. You see that the general trending for the patients is definitely decreased. When we comparing swab with saliva, you see at the disease early of the onset, you see more viral load in the swab comparing to the saliva. But in the middle of the course, or sometimes saliva will be more detect more viral load than swab. So this is the statistical composition of all 19 positive patients over 200 time point sample piling together. You see the red is the saliva, while the let me see clearly. Yeah, and the blue is the saliva and the red is the swab. You see that as what we reflect on the patient one at the beginning, you see more viral load detection on swab, while when it goes to day 10, you see basically the swab and saliva test about equally of detection of the viral load, which also showing on the right side of this table, basically showing the differences of the CT. You see higher on the any of the testing before 10 days, but after 10 days, they're about the same. We're also comparing saliva clear versus saliva fast, which basically is another clinical validation for RNA extraction versus RNA non-extraction. You see that in both cases, both tests in saliva has a very good alignment in terms of the test performance, and this is also being statistically validated. In the table shown on the right, you see that the differences between those CTs are almost keep to zero or no differences along the disease course. And finally, as I pointed out that, depending on the days and the patient, sometimes you detect more in saliva, sometimes you detect more in swab. So we then think to put them together, combination of the saliva and swab, which we have those called spit and swab assay, which you can see that spit and swab assay significantly improve the CT values comparing to saliva alone. So in summary, I hope that I can convince you that saliva is really an ideal biospecimen for a cancer detections or infectious disease. For those cancer derived from UADT, i.e. head and neck, esophagus, and the lung, and also for the respiratory infection on UADT, such as a COVID-19. I'd like to acknowledge the people from my lab and my colleague at the University of Colorado for clinical support, pathological clear lab, consulting, and the biostatistical analysis. Thank you for the Summit Biolabs offering this real-world clinical testing with our team and advisors, and our collaborator at WashU, HSU, MD Anderson, and also the BioSha for validating our proxy PCR. In the end, also would like to thank my research support from NIH or state funding, institution funding, and private foundation support. Thank you.